So this has been a tremendous evening of cases and case-based learning to really help understand some of the different conundrums that we face in treating patients with pulmonary hypertension, right ventricular dysfunction. And I guess, from the panel here, because we've all talked about such very different things, let me start with Ada. What other interventional-based therapies do you think that we'll be seeing, now and even coming down the line, treat patients with Group 1 PH?
Your therapy, I think that the balloon pump for the pulmonary arteries, I think is fascinating. And it was so interesting to hear about it. Yeah, that's right back at you. I think that's one of the most promising ones.
Yeah, no, that is one of the more promising ones, but what about things like the, percutaneous POTS, right? So, and you were involved in that.
What?
The POTS procedure?
Yep.
Right? So, what do you think about that and resurrecting that?
So for those of you, who don't know, so there's both surgical and there is endovascular placement of a POT shunt, which is simply a shunt between the aorta and the left pulmonary artery, basically to unload the right ventricle. It's sort of like putting an atrial septal defect, doing atrial septostomy, except you're only blue from the waist down, not completely. I think there's the only report of the endovascular one is the one that we did. It's endovascularly, it's insane, but you basically go up through well, first you need a CT to show that the left pulmonary artery and the aorta are in proximity. Then you go up with wires down both, punch a hole through the aorta into the left pulmonary artery, snare the wire, and then you basically put a stent across it. And so you've created this shunt that's most notable when somebody exercises because it pretty much unloads the right ventricle. The only patients have done it or referred for it are people who were on whatever you consider maximal tolerated therapy, okay, in right heart failure, who don't qualify for transplant for whatever reason, okay? And the original study, I forget now, I think it was 6 patients. Unfortunately, one of them died during the procedure because we did not realize that the stents were not long enough to cover somebody who was 6'5". It was a crate. Who would have thought of that? We didn't even think about it. So when we created a hole, we didn't have a stent that was long enough to cover it. But otherwise, everybody else survived the procedure. They actually all did do clinically better, some for longer periods than others. It's more or less a temporizing or a palliative thing in people now. So it's a very small percentage of people you would do this in.
But it's there.
It is there. You can do it surgically, but in these people, they're pretty sick. Endovascularly is probably a lot safer. Then we can talk about precardia and ballooning your SVC.
Well, we can. So you said exactly what I wanted you to say, and so how about now we turn this around and I tell you that for patients who have severe aortic stenosis and we can't get in through the aorta, right, to do this, we can do a transcaval puncture. So what you guys did initially, all right, now 15 years ago, is now a much better developed procedure. So that's why I raised the point of potentially could we resurrect this?
I think that's really interesting. We've been thinking about it a bunch too. I was as a fellow there when they were trying to do them at the Brigham. I think the challenge is that depending on how much space. There is a mediastinum, can actually take a bunch of blood. And I think that's one of the challenges, that if the procedure is not done very quickly, patients can bleed either from the aorta or the PA. And then as they bleed, the distance between the PA and the aorta just gets larger and larger until you hit the point where you may not be able to have a stent there, a covered stent that bridges both. And it's a much higher pressure system, of course. But I think in patients with good anatomy who are otherwise end stage, I mean, we've done the balloon atrial septostomy, creating an ASD, which works well in the short term. The problem is that the patient's blue, and sometimes they're more blue than you want them to be. And then their coronaries also get blue, which brings us back to Brad. You know, if their systemic circulation is all desaturated, they do worse than they would if it's just below the belly. I mean, their kidneys are not happy, but if it's, you know, PDAs are reasonably well tolerated, actually. So that's what we're trying to recreate. We do have much better covered stents and much longer stents now than, so I think from a technical point of view, it's more feasible. It's just hard to find the right patient where. I think you're right.
I mean, when we first did it.
Yeah. And so just to get back to your point too about the pulmonary artery balloon, for those of you who hadn't seen this, we discussed this extensively at the prior Right Heart Symposium. But this is a very interesting device that is implanted that improves pulmonary artery compliance. And so Franz, going to you, when you showed the hemodynamics for your patient with treated with sotatercept, I noticed that, you know, the pulmonary or the compliance had gone up to somewhere in around the 2.5 range. So thinking about the work that Evan Britton and Brad Marin did, showing that the inflection point for mortality and heart failure hospitalization is around a compliance of 3, right? So 3 and above, you're good. We can pretty much almost get there with the balloon. Can you get there with sotatercept?
I mean, why not?
That's what I'm asking, because I just don't know.
Well, I'd have to recall in terms of the Spectra data, there's some with compliance on the Stellar data also, I think. But I can't recall if we've met the 3.0 inflection point. That's a high bar, by the way. I mean, that's a high bar.
It is a high bar. I mean, even improving compliance at all, you know, begs the question of, can you improve compliance if the patient's already got severe fibrosis? Right? Because we haven't talked about that in looking at any of these hemodynamics and metrics, elastance, compliance, anything. So should we be looking to see whether or not there's fibrosis in the RV and the pulmonary vasculature?
I mean, I think to a certain degree, yes. I don't really know that we can that we have the tools yet to do that outside of autopsy. I mean, I guess with IVUS, we can look at the vascular wall.
Yeah.
So that would be an interesting hypothesis to test.
Yeah,
but with the heart, you know, we have on MRI, we have T weighting that might help a little bit. I'm not sure that's sensitive enough. I mean, you could tell me. But yeah, outside of biopsy, I'm not sure how we would really even feasibly do that.
Yeah, so with ultra high resolution IVUS and using the peripheral IVUS, which actually can look at a bigger radius, it's a good way to do it. Here.
Going back to increasing compliance, I wonder if it's a matter of time that being on sotatercept for a long enough time, you decrease the pressures, unload the vasculature, and it allows for some of that reversal of the decreased compliance. So you go to a compliance of 1, 2, maybe with time you're able to get better compliance in the larger vasculature. So maybe it starts distally, and then with time you can get more of a global response.
I'm glad you brought up IVUS because I do the balloon pulmonary angioplasties and I do IVUS. Mm-hmm. We don't routinely because it takes time and the procedure is already very long, but I don't think we have a great encyclopedia what the normal pulmonary arterial IVUS should look like. And it'd be interesting to see if we could compile over time.
Yeah,
What the changes are as their pressures get better and they get better. It's a different disease, obviously.
Yeah, very different disease, but boy, some of the changes in the vasculature are striking. I mean, because doing this, we use it with ours, and the amount of like neointima formation in some of these vessels is incredible. They look like, like occluded vein grafts. So it's, yeah, it's really an interesting way to sort of understand like what the vessels should look like and what they do look like. So, and I think, has anybody looked at that and sort of related it to vasoreactivity? Um, you know, well, yeah, just the amount of remodeling seen by IVUS.
Not to my
Yeah, I don't think so. See, yeah, and very interesting. So, all right, and Hap. Let me give this to you because I can. When you have your patients with sarcoid, what are you reaching for to treat them with? In terms of their pulmonary hypertension.
Legally or illegally? No. I mean, it's very interesting and to me, and it always has been, is that people with what seems to be really true sarcoid PAH, who don't have a lot of, shall we say, lung fibrosis and stuff like that, seem to act or respond to therapies just like they had PAH. So there are data, we've published a lot of data both on using ambition kind of therapy in them, systemic therapy, and as long as they don't have a lot of interstitial disease, they do seem to respond just like PAH. The classic one that always blew me away was I had this guy years ago who had no evidence of lung disease from his sarcoid at all. It was all skin disease, okay? And he developed severe PAH with PVRs originally like in the 1800s, right? So we're talking 24, 25 wood units. And he responded to then the juice, IV propranolol, just like he had PAH. Amazing. So, I mean, I don't know, I think the pathophysiology of PAH and sarcoid is just so complicated, and there are so many potential contributors. But in the people who don't have end-stage fibrotic lung disease, I think they are a lot like PAH patients.
Yeah, that's interesting because there's been, at least in the ones we've been involved with, there's so much heterogeneity in how they respond to drug, and there's no way to predict. So I think it goes back to like what you said, one pathway or several pathways affected, you have to find the right combination. Yeah, so anybody in the audience want to ask a question from everyone? Okay, so Brad, you weren't getting away with this. So tell me, when you have somebody who's in shock in the unit, aside from ECMO, when are you reaching for MCS, mechanical circulatory support?
I think a lot of it has to do with the anticipated clinical course based on what you think is set them back. And, sometimes we know there are certain things that are going to take a long time to get better. Mm-hmm. And you're not going to be able to temporize them medically. We also know that sometimes there are certain etiologies that turn around really nicely on MCS, like our patients with, high-risk PE, for example, and for some reason, if they weren't able to get intervened on, or but they coded before they were able to get lysed and didn't end up getting lysed, we know time and support on MCS, they do quite well. I think Getting back to what we were talking about before, the patients that are not responding to those first few critical interventions, when they're not turning around quickly, and you think you have a definitive way to get them better while on MCS. So someone who's a PAH patient who's relatively undertreated on therapy, or a relatively index presentation of PAH comes in super sick. You have those drugs as a bridge to get them better. So you start your initial resuscitation, you try your initial vasoactive strategy, you get them on inhaled EPO or whatever your local vasodilator of choice is. And if you're not seeing clinical course get better and you think there's a way through, and you have the tools, i.e. they're treatment naive or undertreated, to escalate, those are the folks I have a tendency to get them on. And it also depends on where you are, right? So, I spend some nights in a community ICU. I spend some time in a tertiary ICU, and sometimes people get too sick to transfer, and then you don't have MCS as an option when you would have wanted it. So it's kind of a combination of clinical and logistical factors.
So another factor is who's doing your MCS.
Yeah.
Is the idea, because some people will not do mechanical support in people with pulmonary hypertension unless they think there's an out to transplant.
Yeah.
Okay, as opposed to doing it so it's a destination MCS versus a treatment MCS,
Yeah.
which is a very different animal, and very hard to convince a lot of people who do your mechanical support that they don't need to necessarily have a transplant in mind, but that you can use this for treatment. That is a really tough nut to crack.
Yeah. And I think that gets to having a good story going into that, thinking really clearly and trying to identify what you think that precipitant is. Because if you can build a story around it, you can sell it better to the people that actually have to put them on. And I think by and large, though, I will say, at least in the PAH population, outside of our perioperative, peri-transplant population, it's still fortunately a relatively rare event. And that I think it's a real plug for medical management, in that a lot of times you can turn them around, but you have to know what you're doing, and be at a place that's used to handling those patients.
Yeah, I will say one thing also about your case, and that is you mentioned that the patient was discharged home on post-op day 8, right? And so, for people who are used to dealing with the left ventricle, when there's a bad insult to the LV, it's either they're out of the hospital in 3 or 4 days, or it's a month if they survive it. We're not really seeing the intermediate. With the RV, it seems to be a bad insult to the RV. It's it takes a week or so, but the RV eventually recovers. And that's just a very different time course and pattern than what general cardiologists are used to seeing. I mean, do you have any ideas why?
That's a great question. I mean, other than that, most things are different with the right ventricle, right? It's its own creature. But I think the other thing too is that, at least in the pulmonary hypertension population, we're pretty good at modulating afterload. And whether it's the afterload caused by high wedge and left-sided heart failure, that patient population you can usually do pretty well for when they get into right heart failure. And the pharmacologic therapies, they work if you can keep the patient going long enough for the time course of their effects to kick in.
Yeah, so with the medical therapies to modulate afterload, 'cause this is also interesting. I mean, how fast is too fast? right? Because we know from experience treating valves that if you have a hypertrophied RV and there's high afterload with pulmonic stenosis, and you blow this up, open it up immediately, you can get something called suicide RV, right? It can't handle it. So how fast do we want to change the PVR with meds, other therapies?
Another real good one. The patient population that I think about that the most is the portopulmonaries.
Yep.
And I'm sure my colleagues up here have all seen this too. I think out of all the PAH patients that I've treated, those folks can warm up and go into a low SVR state pretty quickly. And that's not always necessarily a bad thing. And some of the data on transplant with liver transplant, that is, in that patient population, shows that if you can get the PVR down, it almost doesn't matter how, whether that's at the cost of cardiac output of 10 liters or more direct effect on the pulmonary vasculature, those patients will still do okay. But those are the folks where I've been burned by pretty aggressively up titrating, and then all of a sudden you find other things are unmasked by the high output failure. And that I've seen that occur in the course of an ICU stay, where someone came in with it was actually an incident case of portopulmonary fractured hip, PVR 12 wood units. We had to get that patient's hip repaired, and they were 50-something years old with no prior medical history up until this time. And, we dig in a little further. They were found to be cirrhotic, and the story thickened. But we swanned them, started them on IV treprostinil, and the unit cranked it up, but very quickly had to kind of back down a little bit on that because we started to see the high output.
Yeah. Yeah, but I mean, it's a good lesson to learn, right? To just get the hemodynamics and watch for high output.
To Hap's point before, you have to get the cath.
Would you not get the cath?
No, of course I would.
Okay. I just wanted to make sure this was still happening.
My mother.
Yeah, I believe. So, all right. All right.
So, in looking, this is directed towards Franz or anyone else. What is you talked about RV diastolic stiffness and some of the markers of that we can look at in the RV. What does the literature show in terms of how other medications have affected RV diastolic stiffness and those parameters over time? There must be some cases like this out there with people who discontinue things. And is there durable effect in the long run if you keep things, the afterload low, where the RV starts to remodel itself just simply now because the afterload is low and it's feeling better about life?
I mean, yeah. I mean, I think your question was, is there information on whether our standard treatments affect diastolic stiffness and how that may affect afterload? Is that right?
Or durable effect, I guess, is
Yeah.
because one of the things your case demonstrated is that even with the drug gone, there was an improvement in those things, at least in the case. Is that something that has been demonstrated with other medications?
So yeah, actually, Rebecca and I published a longitudinal study. I can't recall the N. It was something like 80, 70 some patients, cath, baseline treatment naive, then on combination therapy, and then I think each patient had 3 caths, something like that. One of the earliest changes we see is diastolic stiffness, which seems to go hand in hand with a drop in vascular elastance. I haven't been able to explain how or why those two are coupled so specifically. Maybe Rebecca can answer that for me, but they are. And at the RV Symposium last time, I brought up a hypothesis as to why and how that may affect RV systolic function, which basically has to do with through the Starling mechanism. So yes, that there are changes. It happens also quite acutely. A sub-study of those patients, I think somewhere around 20, where we put them all on and ramped up, not too quickly, I hope, parenteral prostacyclin in the ICU with a catheter in, which was the initial aims of that study were to design a dose response to prostacyclin because we just didn't know. But actually, what we found, interestingly enough, is that acutely within, well, acute is relative, 48 hours, I think, somewhere in there, when they got their first MRI, the diastolic stiffness had dropped. So it's unlikely, I think, in that case, that fibrosis is changing in that short time period. It's probably something to do with intramyocyte changes, maybe tightened phosphorylation, various other things. I mean, I'm just kind of pulling things out of my pocket now, but that's what I think.
Well, I mean, to take that a little further, think about people who've been on systemic prostanoids for a decade and a half, who've completely, pretty much normalized their hemodynamics. I mean, obviously I don't know how you want to define it. They've unremodeled, re-remodeled, whatever you want to call it. I mean, if you did the studies, I'm sure it would show something very similar. I mean, these people, for all intents and purposes, have normalized their function. You can, in a lot of cases, then take them off and switch them to oral stuff, and it doesn't change at all. So they must, I mean, you get into this argument about disease modifying, reverse remodeling. I mean, but if you normalize your numbers and your right ventricle looks normal on an echo, in my mind, you've modified your disease.
I have one.
I'm serious. Like, what's normal?
Well, I mean, I don't know that anybody would, I wouldn't say that people with pulmonary.
You can look at an echo. Oh, that's a normal RV. But
No. It's you get.
what's
We can argue
what's
about
in
this,
between?
But the point is, it
It's in
may
between
look
pH and normal.
but there may be subtle ways to prove that it isn't, and it's hard to imagine that your disease does not go away. So
Yeah.
you're never really normal, but you're about as normal as you're going to get with the disease you've got. That's the way I'd sort of look at it.
I mean, I've seen those patients, and we do an invasive CPET on them, and still, when they exercise, though, they may be near normal at
That's
rest.
true.
Boom.
No, that's true. So, I mean, it's a very subtle thing.
Yeah.
It makes the case for continuing to do provocative testing with exercise,
Yeah.
right? Because this is what the patients complain about, dyspnea with exertion, not takes a while for them to get to dyspnea at rest.
Absolutely.
And that's how we do our right heart caths. So, all right, well, with that, I think we've had a great panel discussion. I want to thank all of our speakers and panelists, and I want to thank all of you for coming, for your asking your questions. Thanks to Aviva and everyone from the NATF for setting this up, and looking forward to seeing everybody back again at next year's Right Heart Symposium.